I think we'll go ahead and get started because we have three speakers today. Today's Medicine Grand Rounds is to honor or to highlight our three Chair of Medicine Scholar Awards, or awardees, for 2019. The Chair of Medicine Scholars Program or awards were established approximately 6 years ago by the Department of Medicine, and they're intended to provide startup salary support for promising young investigators in their transition from acting instructor to faculty positions as assistant professors. This year we have three, and also we award 2 to 4 of these each year, and it's $50,000 a year times 2 years, so $100,000 of salary support for each of the awardees. And this year we have 3 Chair of Medicine scholars. The 3 scholars are Pavan Bhatraju from Pulmonary Critical Care and Sleep Medicine, Angiopoietins from the Division of Hematology, and Rena Patel from the Division of Allergy and Infectious Diseases. Each of them will give a 15-minute presentation and take maybe 1 or 2 questions from the audience, and then we'll move on to the next one and the next one so we get through in an hour. So our first presenter will be Dr. Pavan Bhatraju from the Division of Pulmonary Critical Care and Sleep Medicine, and he's going to talk about phenotyping sepsis-induced acute kidney injury.
Thank you. All right, good morning. The focus of our research in our laboratory is to phenotype acute kidney injury and to understand the genetic and molecular risk of AKI. And so when I talk about phenotyping, AKI, as I will tell you, is a heterogeneous clinical syndrome. And so within that, can we identify biologically similar subgroups? And it's analogous to work that's being done in cancer, but also non-cancer diseases, such as asthma, COPD, acute respiratory distress syndrome, as well as sepsis. And the goal of this work is really informing therapeutics. And so for the next 15 minutes, I'll be talking about how we've been doing phenotyping in sepsis-induced AKI. To start with the case, this is a 55-year-old woman. She has a history of a bacterial pneumonia. As you can see on the radiograph, she has a right upper lobe infiltrate. She developed septic shock as well as acute kidney injury early within her ICU admission. She then has persistent kidney dysfunction and eventually requires dialysis. Eventually, she gets discharged 3 weeks later, but has persistent kidney injury. In contrast, we have another patient, similar presenting illness, also developed shock as well as AKI early within her ICU course. In contrast, she has a quickly resolving kidney function. She eventually gets discharged 1 week later from the hospital and has no long-term kidney function decline. And so I think there's some takeaways from these cases. First, mortality from sepsis is decreasing. On the counter, though, with more patients living, there's increasing rates of organ dysfunction in the hospital as well as long-term. And so the most common form of organ failure in sepsis is acute kidney injury. How we define AKI is a rise in serum creatinine or a drop in urine output. Also, subsequent stages of acute kidney injury are based on how high the rise in creatinine. But it's important to note, so creatinine is a muscle metabolite circulating the blood and is non-specific to kidney injury. And so AKI is common. Up to 1/3 of ICU admissions have some form of kidney injury, and then it's also associated with mortality. So if you look at the Kaplan-Meier curve on the right, with each subsequent stage of AKI, you have a higher risk of dying. There's also clinical consequences. So caring for patients in the ICU is challenging with the edema as well as electrolyte imbalances. And most challenging is dosing of antibiotics as well as other essential medications. There's also biologic consequences. And then when we think about AKI, this heterogeneity, there's many different causes. So everything from sepsis to critical illness to trauma to surgery. There's also different susceptibilities, looking at chronic kidney disease, diabetes, and then within that there's different biologic patterns, and so everything from apoptosis and necrosis to even endothelial dysfunction and inflammation. And despite how common acute kidney injury is and the associated morbidity and mortality, we currently have no proven pharmacologic agents for the prevention or treatment of AKI. And it's not from a lack of trying. So this is not an exhaustive list by any means, but it's some of the clinical trials that have been done in AKI. So everything from insulin-like growth factor, low-dose dopamine, different resuscitation strategies, and septic shock. And one of the takeaways is, while all these trials were negative, they were studying very different patient populations. So if you look at the first clinical trial, it specifically looked at patients with AKI and acute tubular necrosis, while another one looked at patients with AKI requiring dialysis. And the most recent study looked at patients, general patients to the ICU with or without acute kidney injury. So the fundamental problem that we've been trying to tackle is when we combine this heterogeneous population, it limits the identification of genetic as well as therapeutic signals. And then so how can we go about identifying subgroups? So we're thinking, instead of using one marker, creatinine, to risk stratify, let's use multiple markers that are involved in the pathophysiology of AKI. So we use a technique called lane class analysis. It's a clustering methodology. And the idea is, here's a simple schematic, but if we have this heterogeneous population, within that, potentially there are more biologically similar subgroups. To do this, we had a discovery and validation cohort. So all patients had acute kidney injury on enrollment. The discovery population included 800 patients that were enrolled by my research mentor, Mark Werfel, at the Harborview Medical Center. The validation cohort was an external population. All patients had blood collected within 24 hours of ICU admission, and then we chose variables that have been a priori shown to be involved in the pathogenesis of AKI. And so these were everything from demographics, comorbidities, ICU level factors, as well as common laboratory measurements such as hemoglobin or electrolytes. And then in our laboratory with the plasma that was collected, we measured 7 biomarkers of endothelial dysfunction as well as inflammation. And of the ones, angiopoietin 1 and 2, as well as serum tumor necrosis factor receptor 1. And so my mentor for this work was Gerald Herting in the Department of Sociology on Upper Campus. And so what did we find? So when we applied LCA methodology to the discovery population, we found 2 subclasses or subphenotypes differentiated the larger AKI population. 60% of patients fell into subphenotype 1 and then 40% in subphenotype 2. And then if we look on the heat map here, we have all 29 variables that were included in the modeling, and the top variables that discriminated the 2 populations was the ratio of Ang2 over Ang1 as well as TNFR1. We then applied this again independently in the validation cohort and again found similar results, which was nice to see. And again, the 60-40 split between patients between class 1 and class 2. Next, we wanted to see, all right, we've identified these 2 subphenotypes. Do they better help us understand the risk of clinical outcomes than the current consensus definition of staging AKI, the KDIGO stage of AKI? And so here, when we're looking specifically at mortality, we have the 2 groups, the discovery and validation. If you look at the white bar, we have overall mortality in AKI. And then when we stratify them based on subphenotype 1 and 2, subgroup 2 has an almost 2 times increased risk of mortality than subphenotype 1. This persisted even after adjusting for severity of illness as well as KDIGO stage of AKI. We found similar associations with renal recovery as well as dialysis. So then our next question was, we've identified these 2 subgroups. How can we help clinicians potentially take this to the bedside? It's challenging measuring 29 variables. And so working with Lila Zelnick at the Kidney Research Institute, we applied lasso regression modeling to identify a parsimonious model that could identify these 2 groups. And so we found a 3 biomarker model. The ratio of Ang2 over Ang1 plus TNFR1 had good C statistics to differentiate the 2 subphenotypes. Now briefly, just talking about the biology of the Ang-Tie2 axis. So the Tie2 receptor is a phosphorylated tyrosine kinase receptor. It's found on endothelial cells, and it has 2 natural ligands, angiopoietin 1 and Ang2. Angiopoietin 1 is released from parasites and elevated during states of health and leads to, when it binds to Tie2, leads to vascular quiescence. In contrast, when you have sepsis, an inflammatory signal, you have a rise in angiopoietin 2. It binds to Tie2, prevents AND1 binding, and leads to endothelial dysfunction and disruption. And this leads to the clinical syndrome we see of edema and shock. And I think it's specifically important to look at this pathway because in the last 10 years, there's been quite a few preclinical studies that have looked at different drugs to modulate this pathway, everything from agonist to Ang1, antagonist to Ang2, as well as agonist to Tie2. And so I think one of the challenges going from the preclinical setting to clinical is really knowing who are the right patients to test these medications on and at what time during critical illness when there's such a fluctuating state in a patient's care. And so I think some of the phenotyping we've been doing may help inform those decisions. So next we wanted to see, we've identified these two subphenotypes. Do they potentially respond differently to therapeutics? And so we did a reanalysis of the vasopressin versus norepinephrine in septic shock clinical trial. This was a large, multi-center randomized controlled trial published in 2008 in the New England Journal of Medicine. Their primary outcome was negative, which was 90-day mortality. But working with Keith Russell as well as Jim Wally at UBC, we randomly selected 326 patients within this population that had plasma that was available. We measured Ang1, Ang2, as well as TNFR1, and then determined AKI subphenotypes. And so there was 271 patients who had AKI prior to randomization, and then here's the breakdown with the subphenotypes. And then this is a forest plot looking at 90-day mortality. So if you look at all patients with acute kidney injury, there's no difference in 90-day mortality. In contrast, if you specifically focus on AKI subphenotype 1, you see that there's a mortality improvement with the early addition of vasopressin therapy. And then if you look at AKI subphenotype 2, there's no significant difference. And this was even after adjusting for severity of illness as well as the dose of norepinephrine. And so I think this hits home to the fact that when we combine this heterogeneous population, we're losing certain potentially therapeutic signals. And so this work was recently published in the American Journal of Respiratory and Critical Care Medicine. And then when we're thinking about how to take this work forward, so I think one way is if we have better precision with the AKI definition, we can better understand genetic risk. So when we think of genetic association studies, it's often case versus control. However, if the case definition is a lumping of very dissimilar patients, then that could be a challenge. And so we did a follow-up study where we looked at specifically AKI subphenotype 1 versus 2 and looked at genetic risk of subphenotype 2. And we found variants in the angiopoietin 2 gene, which previously haven't been identified in the AKI population. Another way to take this forward is doing a reanalysis of clinical trials or ancillary studies. And so after the VAST study was published, there was a lot of still interest in vasopressin and AKI. And so there was another large randomized controlled trial called VANISH that was published last year in JAMA. This again randomized patients to norepinephrine versus vasopressin and norepinephrine. And they found, again, no difference in kidney-specific outcomes. However, we're working with collaborators to go back and look at that data and see if we can validate our prior associations. Another direction is I've been working with Terry Huff, who's a principal investigator for the CLOVER study. So CLOVER is a large NHLBI clinical trial that's enrolling over 2,300 patients and looking at different resuscitation strategies for patients with septic shock. So do we do a conservative fluid resuscitation strategy or a liberal fluid resuscitation strategy? And so it seems logical to think that if we've identified these AKI subgroups that have different endothelial dysfunction, they may respond differently to the resuscitation strategy. So we're doing an ancillary study looking at that. So in conclusion, AKI is a heterogeneous clinical syndrome. We've identified two subphenotypes of AKI that have different risk of clinical outcomes and better predict these clinical outcomes in the KDIGO stage of AKI. Also, we found that AKI subphenotype 1 responds to vasopressin therapy. There's a lot of people I'd like to thank, but especially Eliza Chai in my lab, and then also my research mentors, Mark Werfel in the Division of Pulmonary and Critical Care, and then Jonathan Himmelfarb in the Division of Nephrology. Thank you.
One or two questions, Pavan?
Yes.
I think that was really very nicely presented and nicely thought out. How about the application to acute lung injury? It's also potentially an endothelial thing, and you're a pulmonologist, so.
Thank you. So there's absolutely other areas that people are doing this, and so especially in acute lung injury, people are looking at subgroups, and is that based on biomarker profiles, or based on gene expression, and also, and like I was saying too, in sepsis. And so I've been focusing on acute kidney injury, but there are many groups who are looking at other diseases and seeing.
Tell me a little bit about that tumor necrosis factor story and whether or not you think immunosuppressants might be resistant.
So I could briefly talk about, kind of biologically, TNF alpha is elevated during sepsis and binds to TNFR1 and 2. Studies have shown that TNFR1 is more inflammatory and TNFR2 may be even beneficial in certain states. And so there's been clinical trials where they've looked at monoclonal antibodies to preventing TNF alpha, and those have been negative. Recently, though, there's been some exciting work finding drugs that exactly block TNFR1. And so in acute lung injury model, it found that was beneficial even in early phase 1 clinical trial. And then there's another drug looking in preclinical. And so I think we're developing drugs that are becoming more selective to the targets, and we're understanding the biology a little better. And so we've been excited about TNFR1 and kind of that continuum from AKI to CKD.
Thank you. Thanks, Pavan. If you have further questions, the speakers will be down here at the end of the session. Our second speaker is Ang Lee from the Division of Hematology, and he's going to talk to us about the spectrum of thrombotic microangiopathies from autoimmune TTP to transplant-associated TMA. Ang?
Sorry for the technical difficulty. Hi everyone, my name is Ang and I am an acting instructor in the Division of Hematology. Thank you for the presentation today for the Spectrum Medicine Awards. For the past few years, I've been working on clinical epidemiology research, primarily in cancer supportive care with a focus on cancer-associated thrombosis and thrombotic microangiopathy. And today I'd like to focus on the latter and speak a little bit about the recent advances as well as future directions in the field of thrombotic microangiopathy. So first I'd like to define thrombotic microangiopathy, or TMA, as a rare disease. TMA is the pathologic manifestation of microvascular endothelial damage in organs such as the kidney due to a variety of reasons, for which non-immune mediated microangiopathic hemolytic anemia, or MAHA, with frank schistocytosis, anemia, and thrombocytopenia is the clinical presentation. It's something we see quite a lot clinically, and we get quite a lot of consult for as a hematologist. So TMA is actually the final common pathway caused by a variety of different conditions. For example, we have our primary TMAs, which include the familiar TTP, HUS, atypical HUS, all of which have a very specific underlying etiology listed on the slide. Then we have a range of secondary TMAs, including systemic malignancy, DIC, drugs, And it is debated whether this post-transplant TMA is a primary or secondary condition. And today we'll focus specifically on the immune TTP and transplant-associated TMA as important prototypes about how this disease can come about. One of the mechanisms or for the pathophysiology for TMA is that it could be a malignant factor or VWF-driven process. Typically under shear stress, the ADAMTS13 protease cleaves VWF at the tyrosine methionine bond in the A2 domain. Complement molecules can either serve as a cofactor or independently respond in the factors for the VWF cleavage. And with inflammation, oxidative stress, and various scenarios, that could lead to excessive VWF multimer formation. So potential triggers for having thrombotic microangiopathy could be related to low ADAMTS13 activity, resistant cleavage, or perhaps abnormal complement activation. So let's first talk about immune thrombotic thrombocytopenic purpura, or TTP. The immune TTP is pathognomonic with severe ADAMTS13 deficiency, most commonly due to an autoantibody to the ADAMTS13 protease. It leads to an accumulation of ultra-large thrombotic factors, platelet aggregation and consumption, as well as microvascular thrombosis. Back in the days, it was associated with a very high mortality without treatment, but nowadays it actually has excellent outcomes with perhaps less than 10% mortality with immediate plasma exchange. Given its information, it's still considered an emergency within the field of hematology, and rapid diagnosis is therefore crucial. In order to study a rare disease like TTP, we first had to establish a multi-institutional cohort registry, or a cohort study, over a 15-year span between the Harvard Consortium and the University of Washington. I was involved in the initial study as a resident at MGH, but later on expanded the study when I became a fellow here at University of Washington. In this retrospective cohort, we had approximately 450 patients with TMA and available ADAMTS13 testing, among which 124 were diagnosed with immune TTP with ADAMTS13 less than 10%. Using that cohort, we performed various studies to address the question about diagnosis and future relapse. So here's a slide about one of the scores we derived for a rapid diagnosis for TTP. While ADAMTS13 deficiency is pathognomonic for diagnosis, it can often take days, if not longer, for it to return when we need to make the decision more quickly. So using the consortium database, we examined various, I believe 29 different baseline clinical and laboratory parameters at the time of presentation, and derived as well as validated a 7-point score called the plasmic score. And that can be used to stratify patients into different risk categories. And I'd like to refer you to the website listed on the slide for specific ways to calculate the score. But looking at the derivation and the validation cohort on the left-hand side, you can see that out of the 200 derivation and 150 validation cohort, the score had a C-statistic of about 0.96, and a C-statistic of an ideal test should have a number of 1. Using an independent data set specifically from our center, University of Washington, and Harborview, that was added later on, I looked at the performance of the plasmic score as an additional external validation. Based on 108 patients who underwent ADAMTS13 testing, the validation C-statistic was still good, about 0.94, whereas the low to intermediate category of up to 5 points only misclassified 2 cases of TTP out of 83, and the high-risk category correctly classified 18 out of 25 cases. Now, in addition to being a prognostic biomarker, it's interesting that the plasmic score may also appear to be predictive, as shown on the left-hand side by the Kaplan-Meier curves. When patient had high plasmic score, those with yellow and green lines, those who underwent plasma exchange had nearly 100% survival, whereas 2 out of the 3 people who did not undergo plasma exchange died. However, among those with the low to intermediate score, with the red and blue lines, you can see the even splits, there was no noticeable difference in survival regardless of plasma exchange. And notably, the majority of them did not have TTP. So while the results in the low-risk group was not surprising, It was intriguing because it would suggest that among patients with other types of TMA besides immune TTP, plasma exchange might not be beneficial. Lastly, we looked at a slightly different question, focusing specifically on the 124 patients with immune TTP and see if we can find predictors of TTP relapse in the future. We know about a third of the patients or more experience relapse after initial remission. And in this study, looking at these factors, we found that there are a few factors that are associated with higher risk for relapse, specifically having had a prior TTP episode at this current presentation, having a non-O blood group, which is typically associated with higher VWF levels, a younger age. Alternatively, rituximab, as expected, was protective. However, it had a time-waning effect, lasting about 3 years, and as you can see, the crossover for the relapse-free survival on the Kaplan-Meier curve on the right-hand side. So these clinical studies combined give us some insight on perhaps which patients to be more aggressive for the rapid initiation for plasma exchange, as well as those who may benefit the most from an upfront rituximab or other immune suppression strategy. Now, shifting gears a little bit, I would like to talk a little bit more about transplant-associated thrombotic microangiopathy. Unlike TTP, this disease is unfortunately poorly understood, and it has a much more heterogeneous course. It does not have a gold standard diagnosis, and finally has associated with a very high mortality. So it's one of those complications that we see after allogeneic transplants that we unfortunately don't know what to do. Furthermore, we really have no understanding about the pathogenesis behind that. So in order to do that, I employed a very similar approach, and this would be a single-center retrospective cohort study over a 10-year span with uniform data capture and adjudicated clinical diagnosis, since there was no gold standard for it, unlike TTP. So from here, we have about 2,000 allogeneic transplant patients, among which 192 patients were adjudicated to have thrombotic microangiopathy, or about a cumulative incidence of 8% at 100 days post-transplant. I first looked at the risk factors associated with the onset of the disease from this cohort study, and then performed various case control studies for both biomarker discovery as well as genetic association studies to perhaps discern which pathway is involved. So first, looking at the risk factors associated with transplant-associated TMA, there are various significant factors shown in this table. However, just focusing the post-transplant section, they can be broadly categorized as 4 different types: graft versus host disease, or GVHD, alveolar hemorrhage syndrome, systemic infection, or drug or idiopathic. The most interesting and the strongest association found in our study is the increasing relationship between TMA and higher grade or clinical severity of preceding GVHD, and it's something that we decided to explore a little further. The same post-transplant risk factors shown in the previous slide can actually also help stratify patients into different prognostic risk categories. As shown in the Kaplan-Meier curve here, those with the alveolar hemorrhage had the worst outcomes, followed by systemic infection, followed by acute GVHD, and finally those without any clear inciting triggers. So I believe, at least based on the study, that unlike TTP, transplant-associated TMA is not a singular disease. And it's almost like what Pavan was discussing previously. It is a heterogeneous disease and a final common pathway resulting from various entities, each with its own prognosis and perhaps management. So to dissect how we can treat each one of them, we decided to look further and do a nested case control study for the biomarkers. Since the majority of the patients with TA-TMA had preceding GVHD, we wanted to see if there are any biomarkers at the onset of GVHD that we can find that can predict who will later on develop TMA that may perhaps warrant a slightly different management strategy. So to do that, we did this nested case control study using weekly bank biospecimen from our repository. And to select the cases and controls, we used a method called incidence density sampling. So we find all the patients with a diagnosis of TMA that we had samples for, and then match them with appropriate controls that had a similar matched time points who did not have TMA, and then we furthermore match them on the prior onset of GVHD timing. We then performed specific assays for ADAMTS13, von Willebrand factor, and complement activities, sort of the two main pathways that we're interested in. And we're currently also actually collaborating with Pavan on some of the endothelial marker studies as well. So here's some of the preliminary data for this study that we're still currently analyzing. We found that at all times, but most profoundly at the time of GVHD onset, which is the time point we're mostly interested in patients with TA-TMA had higher levels of terminal complement activation, C5b9, and lower levels of ADAMTS13 adjusted to the amount of EWF antigen available. And this finding suggests that our previous hypothesis regarding this crosstalk between von Willebrand factor and complement could be a potential trigger within the pathogenesis for the TMA resulting from GVHD. And we're currently doing further analyses for specific modeling about how to incorporate these findings into a more prognostic or perhaps predictive model. And lastly, something else that we're trying to do currently is to essentially try to explain if there are rare variants within the von Willebrand factor or complement gene pathways that can predispose to the development of this disease. And to do this, we are actually both utilizing an existing genome-wide association study at the Hutch that's been collecting data for about 15 years, and we have some overlapping patients from 2006 and 2011. And in addition to that, we're also doing our own whole exome sequencing to try to see if we can identify specific variants within this pathway for either von Willebrand factor, ADAMTS13, or the complement pathway. This is going to be an ongoing project, and I'm hoping to complete by the end of the year. So with that, that was a quick whirlwind tour for various clinical epidemiology studies on thrombotic microangiopathy as a rare disease, jumping from what we know very well, immune thrombotic thrombocytopenic purpura, to something that's a little bit more unknown, post-transplant TMA, using similar sort of study principles within clinical epidemiology. So in summary, that we know that immune TTP is very specific. It is associated with severe ADAMTS13 deficiency. We can rapidly diagnose, make a rapid diagnosis and treat it appropriately. Whereas for transplant-associated TMA, a lot more is unknown, and we need further study to understand the underlying pathogenesis before moving on to the therapeutic targets. I unfortunately do not have time to share with you my research findings cancer-associated thrombosis, but more than happy to discuss that with anyone after the talk if interested, and I really like to thank my mentors and collaborators here. Thank you so much.
One or two questions for Alan? So I have one then. Can you comment on the relative contributions of, say, von Willebrand factor activity versus endothelial activation dysfunction in your various TMAs, and what we know about that, or what you want to explore?
Yeah, so the question is if I know anything about the von Willebrand factor versus endothelial dysfunction in the TMA patient, and presumably post-transplant setting. I would say that recently, most people have been focusing on the complement pathway and the complement involvement in this disease, and less attention has been put forth towards the von Willebrand factor or endothelial dysfunction pathway. Previously, some people have found that, well, we know that the ADAMTS13 tends to be normal or only slightly abnormal within this disease, so it's very different from TTP. What people have not looked into, which is one of our hypotheses, is that the von Willebrand factor are perhaps more resistant to the normal ADAMTS13 cleavage, and that may be the mechanism, part of the mechanism why patients still get TMA in this setting, with or without a complement involvement. Since it is an endothelial disorder, I think there's going to be some endothelial activation, but I don't believe there's as much data in that area yet.
Mm-hmm. Especially since both angiopoietin 2 and von Willebrand factor are stored in the same bodies in the endothelial cells, so there has to probably be some connection there.
I believe so.
Okay.
Thank you.
Any other questions? Thanks. And our third chair of medicine scholar for 2019 is Rena Patel. And Rena is an assistant professor in the Division of Allergy and Infectious Diseases, and she's going to talk to us about HIV and reproductive health, navigating the space between a hard place and a rock.
Thank you, Conrad. Let's see. Good morning, everyone. It is fantastic to see so many familiar faces, from our former chair to incoming intern, and many others. I'm really deeply honored to receive this recognition, and have to acknowledge that perhaps my biggest accomplishment to date seems like getting my two kids under ages of 6 out the door and to their 2 separate drop-off locations before making it to Grand Rapids this morning. And a warm welcome to Dr. Young, and kudos for sending out one of your first communications to the Department of Medicine on a personal note. As the feminist saying goes, personal is political. So let's get started talking about HIV and reproductive health. And by the end of this talk, you'll see why my title is named so. So HIV is a global disease. However, it disproportionately affects those living in sub-Saharan Africa. And here you can appreciate that's mostly in Eastern and Southern Africa, where 60% of those living with HIV and receiving treatment for HIV, which we call antiretroviral therapy, ART, are women and girls. And when we think about reproductive health for women, it helps to look at this from the life cycle of a woman's perspective. And pardon the heteronormative nature of this slide, but it's meant to convey that women spend a lot of time either preventing pregnancy or wanting a pregnancy. And this is a really major consideration, and not to take this into account when dealing with a major global disease like HIV is a true disservice to all people. And women living with HIV, just like women living without HIV, desire children. They also don't want unintended pregnancies. So up to two-thirds of pregnancies in sub-Saharan Africa are unintended. And my colleagues have published data from Kenya that shows 70% of women want to delay their next child. To the effect that the World Health Organization and UNAIDS has acknowledged that family planning is one of the 4 key pillars for preventing mother-to-child transmission of HIV. Why not prevent the pregnancies in the first place? So how do that? Contraception. And today we have such fantastic modern contraceptive methods to do so, and even more research in expanding the method mix and including methods targeted for men. We know it improves maternal and child health, and there has been demonstrated data suggesting that it has larger socioeconomic benefits. So here are some of, not all, but some of contraceptive methods. With no method, in a typical year, a woman who is sexually active is expected to get pregnant about 85% of the time. I want to highlight the very top row, contraceptive implants, which is not a common method in the U.S., because of some early negative misinformation, but it is even more effective than male or female sterilization. So this method contains synthetic progesterones. There are 2 types containing levonorgestrel and etonogestrel, and they work immediately, can be reversed immediately, and last for 3 to 5 years. So there's no user action, i.e. the woman doesn't have to take a pill every day or come back to the clinic every 3 months to get a depot shot. And implant use is increasing worldwide. In our setting, where I have been working in Kenya, up to 15% of women are now starting to use implants. And in sub-Saharan Africa, Kenya has the largest uptake of implants. Let's switch sides to HIV. it is really exciting to be an HIV provider today because we have so many great medications. And when an issue comes up regarding the HIV medication and another one due to a drug-drug interaction, I have many options here in Seattle for my patients. When dealing with my patients in Kenya, I don't have as many options. And this is much better than the arsenal we had even 10 years ago for treating people with HIV in resource-limited settings. And so the two drugs that I'm going to focus most on are nevirapine, which is in the second column, and efavirenz. And in 2013, efavirenz containing ART became available internationally, and it was it was a really significant event because the first time we had a single combination pill to treat HIV. A patient could take one pill once a day, just like their hypertension, maybe even better than their diabetes. So this was a really significant factor for treating HIV. Of course, as women started using efavirenz more, we started seeing case reports of contraceptive failures. It is notable when the most effective method starts failing, i.e. women start having pregnancies. And so, there's a potential, this is the leading hypothesis for the drug-drug interaction. Both contraceptive hormones and antiretrovirals are metabolized by CYP450 enzyme activity in the liver. And so, particularly when you have efavirenz on board, it induces, i.e. increases the enzymatic activity and shifts the contraceptive hormone towards its inactive metabolite. And therefore, you have less of the circulating active hormone and more of the inactive hormone. And this has played out in pharmacokinetic PK studies. You can see here in this graph, the green is women with no ART, who are receiving a levonorgestrel implant, and then those women who are receiving efavirenz-containing ART have 50 to 70% decreased concentrations. And in this the study I'm showing here with my colleague Kim Scarsi, 3 of the 15 women went on to actually become pregnant within the first year of implant use. This is really remarkable, and very limited clinical data, a retrospective chart review, a pooled clinical trials data study with one pregnancy detected that seemed to, again, signal that there was an increased risk of implant failure. And we published our work from Kenya, working with the HIV treatment program called FACES, using electronic medical records. And what I want to highlight here is the row with the red box that efavirenz, women who were using implants and efavirenz-containing ART had nearly 3 times the rates of pregnancy as women using implant or nevirapine-containing ART. However, so there's a negative signal there, but what are the alternatives? So should women instead use DMPA and efavirenz? And here you can see that the rate ratio is nearly 2 as well. And while this finding is not statistically significant, our subsequent findings are. And so I'll draw attention to this later. We went on to, as part of my K work, expand this work with 80,000 women in Kenya again, in Western part, with the International Epidemiology Databases to evaluate AIDS, IDEA. And here, again, with this data set, we show similar finding that women are at 2 times risk of pregnancy when using that particular combination of efavirenz and implant, and when using DMPA at even higher risk. This has to do with the absolute baseline low risk of pregnancies with the implant. And as you can imagine, there's been a lot of criticism of this work, because one, it's electronic medical record analysis, and any of the providers in the room can tell you, that there's a lot of things that go in there and come out that aren't quite useful for analyses. Number 2, this was from a resource-limited setting. I can't tell you the peer reviews we had in publishing this data that said this simply can't be right. It's from a resource-limited setting. What is the quality of the data that you're using? So we went on to do this, what we're calling a validation study. We use probabilistic sampling. So we have the study population. This is a simple schematic. Study population with 80,000 women using stratified random subsampling, we followed up with detailed file reviews for 5,000 women. And from there, we conducted a further phone interview with about 1,000 women to adjudicate our primary exposures of contraceptive method, ART regimen, and our primary outcome of pregnancy. And here, we find very similar findings, that women using implant efavirenz have 3 times higher rate of pregnancy as opposed to women using never-apparent implants. So I'm really excited that this gives a lot of teeth to the multiple data sets that are used for analyses with from resource-limited settings. That yes, no EMR is going to be perfect, but in general, we're able to validate the overall findings. And I'm really excited that our work has had so much policy impact. So at the time, there was a lot of confusion about what to do. Should women be offered implants who are using efavirenz containing ART? And Malawi went ahead and said, no, don't give them implants, use DMPA. Our data says, well, actually, women have higher rates with DMPA. South Africa was on the verge of a robust nationwide rollout of implants, and they recalled implants for women living with HIV, which just, a blanket statement like that, as you can imagine, does more disservice. And so I was really excited to see that the WHO specifically cited our study in saying that women generally should be allowed to use implants. They rated it as a medical eligibility criteria, MEC2, saying benefits outweigh risk. Similarly, the CDC has cited our work in coming to that same recommendation. Kenya never implemented restrictions that they were contemplating at the time. Malawi, since then, has reversed. We have not made a dent in South Africa. So women in resource-limited phases living with HIV face limited options. What can we do here? And this is the cartoon. It's kind of being stuck between a hard place and a rock. You don't have too many options for contraceptive methods. You don't have too many options for ART. Let's tackle the contraceptive side first. What about IUDs? The non-hormonal IUD would not have a drug-drug interaction, or even if the hormonal one did, potentially would still maintain its efficacy for pregnancy prevention. Well, there are marked limitations in resource-limited settings using IUDs, from lack of sterilization equipment to widespread community misbeliefs regarding IUDs migrating to the head, to the legs, etc. So it's not easy, and my colleagues in the contraceptive world have been working long and hard to get greater uptake of IUDs. It's also hard in the U.S. And DMPA is an alternative, but as you saw, user action is required every 3 months to come back to get an injection, and women don't always come back, or when they come back, there are facility stockouts, or for those of us who work in resource-limited settings, there are often professional health strikes. The nursing strikes are infamous in Kenya, and so women don't always get the DMPA when they need them. What if, so the implants are approved to be used for 3 or 5 years. What if, and as you saw the PK curve, there's a tail where you would imagine that it is more susceptible to the drug-drug interaction. So what if you only used it for 2 out of the 3 or 3 out of the 5? And our analysis shows, as you can see from the blue lines here, that there really isn't an inflection point where the pregnancy rates take off. So unfortunately, that is not an answer. My colleague Kim Scarsi conducted a study with doubling the exposure, i.e. putting in 2 implants instead of 1. Since the reductions were 50%, if you double the implant, can you get back up to about 100% and maintain efficacy? And unfortunately, it doesn't work. So here the blue line is the levonorgestrel naive group, and the red line is the double dose. And as you can see, it's barely hovering above the green line, the single dose ENG implant, and nowhere close to the blue line where we need it. So that too is not an answer. Okay. How about switching side to the ART? There's been a lot of hope in the HIV community that lower dose of efavirenz, so like many drugs, it was first prescribed and approved at 600 milligrams, and later we've learned that we can dose it at 400 milligrams with equivalent efficacy. And people have significantly lower side effects implicating that the exposure must be lower. So if we do that, can we overcome this issue? And a PharmD student working with me has done some population-based PK modeling that shows, unfortunately, the reduction is only, the increase in the levonorgestrel concentrations are only about 5 to 10%, so nowhere near overcoming that 50% gap that we needed. And I am leading a PK study in Kenya called PARVI, where we are answering this question with empiric data. And unfortunately, I can't share it because it's submitted to a conference. So what about an alternative ART? Up until now, all the other options have been inferior to efavirenz. So if you're focusing solely on HIV, efavirenz was the right answer. Now, we have another ART regimen, dolutegravir, in the mix. It first became approved in 2013 in the U.S., and 3 years later, which is astronomically short duration for getting it to resource-limited settings, we had its first use in resource-limited settings. In 2017, Brazil, Botswana, and Kenya started limited rollout of dolutegravir in their national programs. And in 2018, the WHO recommended it as the first line. Except in May-April 2018, a study in Botswana showed that there might be a potential, there may be a potential association between using dolutegravir during pregnancy, early during conception, and neural tube defects in the infants being born. And so there was a market scare in the HIV community, a pause to all these dolutegravir rollouts. And the initial country responses in Botswana and Kenya, as an example, was efavirenz is a preferred first line for women of childbearing age, ... However, adult men can be transitioned to dolutegravir. So as you can imagine, this did not go well with women living with HIV. This is our largest international AIDS conference in Amsterdam in 2018, where women's groups were protesting left and right and saying, how could you make this decision without consulting with us first, asking us, what do we want? We want choices. We want to be the ones making the decisions. Inform us of the risks and benefits, and let us make the decisions. Please don't mandate that women should only be on efavirenz. And this is because dolutegravir has marked benefits over efavirenz. So there's no equipoise there from an HIV alone point of view, but dolutegravir is a superior drug to be used. The WHO went on to say, well, women could use dolutegravir if they are on effective hormonal contraception. Well, where is the data to suggest there aren't any drug-drug interactions? And there's only one healthy crossover study with sparse sampling that's required by the FDA that the company conducted, showing that there likely wasn't a drug-drug interaction with oral contraceptives. However, no data to date that suggests there aren't drug-drug interactions or other issues with other contraceptive methods. Ours, again, will be the first study to show this, and I hope to share it in the next 6 months. Botswana has a small sparse sampling PK study, and the Dolphin 2 will be looking at this in postpartum women using implants and DMPA. So I think dolutegravir is probably the solution, but there's been a lot of confusion among women living with HIV, providers on the ground who are treating these women, and policymakers around the world about how to handle dolutegravir. So I think it's going to take a lot of undoing, and we're doing a mixed method study in Kenya to understand how patients and providers are receiving these messages and how they would rather receive these messages. It's also prompted, as I mentioned, the neural tube defect scare, which now apparently there's less of a signal, and everyone is saying go ahead and use dolutegravir in both men and women. Really has prompted people to institute pharmacovigilance programs in pregnancy. As you can imagine, women are at least half, if not a little more, half of the world's population, and yet we have so little data on pregnancy outcomes in women. And so I'm really excited that we, just a few weeks ago received a multi-million-dollar grant from NICHD to build a multi-regional infrastructure for pharmacovigilance in pregnancy, and we're starting in Kenya and South Africa first. So in conclusion, I really want to suggest that we're at a critical point in the HIV community where we really need to shift how we approach HIV care. outside of that, as you heard Pavan and Ang mentioned, we're making leaps and bounds regarding personalized or individualized medicine. Yet, in resource-limited settings, we are still stuck on this one-size-fits-all model that we need standardized, streamlined public health approaches. And what I want to argue is that it's a disservice to women living with HIV and other women to suggest that having a women-centered approach where you give people options is in somehow opposition of good public health. And this is to note that women's needs change over time. You know, in our settings, we talk about options routinely with our patients, and shared decision-making is the norm. And we focus on informed choice, even in the setting of imperfect information. But the challenge here I do want to convey is that, you know, a typical provider in the public care setting in Kenya sees over 100 patients in a day. So how to do that effectively in the less than 5 minutes you have with that patient is a real challenge. And I don't have an answer to that yet, but I am working on that answer. And I just wanted to put this slide up as this is one of the several projects I'm working on. I do mixed methods research. I have a background, a master's in sociology, and I do both quantitative and qualitative work. And the first bucket stream of my work is on HIV reproductive health and pharmacology, of which I've presented a lot of our data today. But I also work in point-of-care technologies for HIV treatment monitoring. And this is really exciting work in collaboration with Lisa Franco at Seattle Children's and Barry Lutz in bioengineering, where we're trying to design point-of-care assays to detect viral load and drug resistance for HIV treatment monitoring. And lastly, a really small but very near dear project to me is Harambe, which is attempting to increase HIV testing rates among African immigrants in the U.S. And I work with Roxanne Karani on this project, who's in the audience today. Thank you so much to the Department of Medicine, my division. I really want to thank the Center for AIDS Research, CFAR, and Department of Global Health, particularly my intellectual home, the International Center for Clinical Research, and all my mentors, collaborators, and of course funders, because it would not be possible without them.
Largely questions?
Thank you, Rena. Wonderful talk. You mentioned male contraception. What's the uptake there? What's the future? And would you see any of those interactions there as well?
Great question. So I will point to others in the audience who are far more expert in this. I'll say one thing. At the moment, the male condom and male sterilization are the only two contraceptive male options available in resource-limited settings. There's considerable pipeline of products that are largely non-hormonal for male contraceptive, and others can correct me. You know, I don't know if the exact drug-drug interaction issue will come up, but invariably something will. And I think it's really interesting that if many of these contraceptive methods were male-focused, I don't think the FDA would have a policy where it only requires one healthy PK study to approve the drug for all vast number of contraceptive methods. But I'm also excited to say that I hear that there's internal discussions in the FDA to require more than one study to get marketing approval for drugs.
So I think that we've reached the hour's limit, so I want to thank the three presenters. Thank you, Rena. Thank you, Tom. Thank you, Pavan. One last round of applause.